to talk about mental health in schools from the perspective of our designated agencies. And we have a couple of people online. We appreciate you joining us and also appreciate that you're not here because the weather is not great. So thank you. And I think we have Derek Hoy and Matt Hoppenink. Welcome.
Thank you very much. Yeah, I can introduce myself quickly. My name is Matt Habedank. I am the Director of Early Childhood and School-Based Services at NCSS. And the division I oversee encompasses our Parent-Child Center programming, which in NCSS is part of the designated agency in our region, and all of our school-based services, which includes a couple behavior interventionist programs, school-based clinicians, PBIS consultants, and our approved independent school. And thank you for your time today. I had the chance to come down and testify to House Healthcare probably in April at the end of the last session, and I enjoyed the time in the committee. I thought y'all did a great job asking a lot of great questions. It was a good discussion, so it's nice to be back.
Great, thank you. Thanks for being with us.
And I'm Derek Hoy. I have a few different roles. I'll explain that. I apologize if I cough. I tested positive for flu, so good thing I'm not there in person, but I do apologize for not being there. I'm the CFO for NCSS, Franklin Grand Isle counties. We serve in 22 schools in our counties, about 9.9 million in revenue. I'm also the acting CFO in Lamoille County at Lamoille County Mental Health Services, and we serve in 18 schools in that county, about 4.8 million. And then I'm a resident of Chittenden County and have some personal experience with school-based mental health in the Champlain Valley School District. So that's a little bit about me and looking forward to this conversation.
Thank you. And I think that we have slides that you've brought in, and so let's start from the beginning.
Sure. Yeah, I like Amy said, I heard her talking before we hopped on. Laurel, it's nice to follow Laurel because she kind of laid the groundwork for us a lot. I think she talked about some of the things that we might have gone into. So I would say ask away with any questions you have. I mean, I would say my goal of being here today is to really provide you with the information that you're looking for regarding Success Beyond 6, how the funding works, whatever pieces of that information help you. That's what I would seek to get into. So the Success Beyond 6 partnership between DAs and local schools, it's right now we're in 64% of the schools in Vermont. That's probably a little bit higher in our region in Franklin and Grand Isle counties. I know Laurel has said that fluctuates a little bit. It's down a little bit right now, and she talked about some of the reasons for that. The goal of the programs that I oversee and our school-based programs in general is to start working with kids, get them in, provide supports and services, try to identify needs, connect them with both school-based services and supports in home and community settings as is necessary and appropriate, and then hopefully transition them to a less restrictive level of care or completely independent in the school day, depending on what the needs are. So it's, we're always sort of in to work ourselves out of a job as quickly as we can, which with some kids goes very well and happens relatively quickly, and with some takes a lot longer. So the system's designed to be very flexible. And I would say, a part of the line of questioning, I was in House Ed last week, and one of the things they asked me to talk about, and I think you sort of hit some of this with Laurel, is how does the system work best? Is this services provided by DAs and through the Success Beyond 6 funding mechanisms and other mechanisms that Laurel talked about? Is it provided by schools? How does it function best, and how do we best meet the needs of the kids in Vermont? I would say it's best in partnership. There are a lot of needs for kids in Vermont schools. There is a limited pool of resources, and it's resources that DAs have access to some of those, schools have access to a different set of those, and it's on all of us to leverage those resources to maximize their effectiveness. To work together to identify, and it really is region by region and sometimes school by school, what are the resources the school has internally? What are the needs they have that we might be able to step in and help provide? And how do we, like I said, maximize the resources that we have available and leverage them to meet the need? So I think in a broad sense, that's how I sort of view our role and the collaboration in meeting this end. Do you want to go through the nitty gritty of the financials, Derek?
Yeah, that would be great.
So Success Beyond Six has been such a critical program for our system of care for many years. And I arrived at NCSS in 2020, and that's right at the height of the pandemic when a lot got disrupted in the school systems in terms of staffing and what have you. But for many, many years, Success Beyond Six had run at a very solid clip, and this partnership and collaboration and the financing of it was running well. But like most things, it got disrupted around 2020, and we've been looking at our own data and trying to figure out what is the future of this going to look like. And I really appreciate how Laurel laid this out beforehand and some of the partnerships and really highlighting collaboration because that's what makes Vermont special and successful in what it does. Success Beyond Six was designed to be collaborative, to share costs, to leverage strengths. And I think we're feeling a little pressure right now on a number of different fronts, and we could get into a lot of that about staffing, hiring. If the DA system can't hire the people, but a school still needs to provide the services, the school may opt to just go hire directly, and then that cost has to get passed on somewhere to taxpayers. But the way Success Beyond Six funding was designed is that Medicaid helps cover the cost of those services in the school for the DA to provide it. So we bill Medicaid, and we get paid in a lot of cases fee for service or a case rate, but it's Medicaid dollars. And then there's the federal match component, which is right now 42.17%. And so that's a critical number because it's that 42.17% that we at least need to charge to the schools because the schools will pay the match. And when we invoice the schools that number, that is really supposed to be an incentive and a value add for the schools to really get a good deal on high quality services. Because it does go to this specialization that a mental health designated agency has the specialty and staff, can provide the training, has the scale that can serve all these schools across the state. And so that's really the concept of this model and how it does kind of present a win-win to both the school and the DAs. But we've kind of seen that shaken up a little bit, again, as schools have opted to maybe go hire directly and bring staff directly into their schools and have to build an infrastructure to support those staff and what have you. Whereas a DA might have 200 school-based, service individuals in a school. A school has to kind of replicate that. So there really is a value to working through this model, and that's how we've been trying to figure out how is this going to look going forward. How does this play into the massive reforms that are being looked at in terms of educational funding as well, and that Success Beyond Six may be the answer to that and cover a lot of bases. We could go further into these details about what's a case rate, what's fee for service. But at the end of the day, it really is what is the DA bringing down for Medicaid, and then what are they charging the school, and what is the school district paying, and what is that line item on their budget?
I think I have a question. I'm trying to imagine like the steps that this takes. So the designated agencies bill Vermont Medicaid. So let's say DEVA.
Mm-hmm.
The schools contract with the DAs, say, we'd like to purchase $10,000 worth of services. The schools pay the designated agency the 42% and change match. That goes to the designated agency, correct?
Mm-hmm.
And then you bill Medicaid. Medicaid pays the designated agency only the 57%? That, and so that 42% is not coming out of general fund dollars. Okay, I was trying to make the leap to general fund. Okay,
Yeah, we tried to lay it out here that when we bill Medicaid, we bill a full Medicaid rate. And so that full amount of dollars, let's say, it's $10 million comes to the agency.
Mhm.
But we've already made an agreement with the state. You're going to have to pay us back that 42.17%. So on all of our financials, we always have to account for that and say, we didn't earn, like, all these dollars are not ours. We have an obligation to pay the state back this match rate. And because of that obligation, that's then a very easy way to follow. Now we go bill the schools for covering that portion.
Great, thank you.
And that comes out of education fund.
And that comes out of the education fund.
Yes, and that's a critical point. It has to be clean local dollars. It can't, because you can't use federal dollars to, match federal dollars and all that. It has to be the clean local dollars, which would mean the local tax base, the tax revenue.
Okay.
Yeah.
So school budget.
And if a school does not utilize the designated agencies, then that $10,000 of services that they're contracting for the school that comes out of the education fund, the complete $10,000. Okay,
As opposed to the 4217.
Yes.
Okay, got it.
okay.
Yeah.
Thank
And
you.
I'm not a specialist in educational financing, but I have wondered how does a school and what does that cost structure look like? It's always seemed like it would be more challenging to navigate that cost than it would be to operate in this system. But I don't know the specifics on it.
Thank you.
Yeah, I mean, I think the bottom line is it allows schools to access services for a portion of what they cost. And I will say a lot of our contracts, and I can only speak to NCSS, but I'm guessing this is true statewide. As we went through COVID and hit the Great Recession, and you hit or the great, people left the workforce a lot. Inflation hit. The cost of providing services was rising faster than our reimbursement rates through Medicaid. So one of the levers for school programs that we had to pull was raising the contract rates. So where that 42% is kind of the baseline for what we need to do to match Medicaid dollars, the contracts may be more or less than that, depending on what the actual cost of the position is. It's still a fraction or a portion of what the cost of service provision is, but it doesn't always sit right at that 42.17%.
Okay, so if Medicaid pays you $100 for a service, but it costs you $110 to provide that service, then you've had to bill the school not only the $42, but an additional $10 on top of it.
Yes.
Yes, that's exactly right.
But still less than $110.
Still less,
Yeah.
for sure.
Okay.
Yeah, and I will say we try to keep that as low as we can. I mean, we part of our partnership with schools is recognizing that they have significant budget pressures and costs that they have to meet too. So that's part of the what we aim to do with schools is keep our costs as low as possible. Amy, can you go back to the previous slide real quick? I just wanted to talk about those three sort of service billing levers that we kind of pushed there. Fee for service, I'll talk about first, although it's the middle one. That I think that's where Success Beyond 6 started. I think that's what a lot of people think of when they think of Success Beyond 6, and that's kind of the behavior intervention model. A staff that's one-on-one with a child all day long, that has a relatively intensive behavior plan, that's very individualized. They're in the public school, but they work with a kid for an hour, they bill Medicaid for an hour, they get paid for an hour. That is kind of one of the higher end or more intensive services that we provide that are embedded in the schools. That's one way that funding stream is leveraged. Case rate is another one. Most of the case rate services are school-based clinicians and PBIS, positive behavior intervention and supports consultants that are in schools. They carry a caseload of 8 to 10, maybe 12 kids that have individualized care. For school-based clinicians, they're probably being seen during one-on-one sort of what you'd think of as traditional therapy time. To build down a monthly case rate for those students, we have to hit a 2-hour threshold. But then that's the payment for the month. The beauty of that system is it allows for a little bit more flexibility, both to take a couple non-Medicaid kids onto that caseload that you're not directly billing for, but obviously kids without Medicaid need supports. So it allows you to build some of that excess to serve those non-Medicaid kids into that structure. And they do a ton of work school-wide, a lot of classroom consultation, consulting and running the school-wide behavior system for PBIS consultants, work with teachers, work with staff, training. It's kind of, it's that those positions and that funding stream are designed to provide some flexibility in that way that the fee-for-service mechanism doesn't necessarily provide. And then CERT is the DA-run independent schools, which is a daily rate per kid. And they have to be there for a certain amount of time during the day. I think it's 2 hours is the threshold for when they have to be there, and you pull down a daily rate. So it's a part of it is designed really to make that funding stream as flexible as possible, and part of it is designed to get upstream. We want to begin getting in with kids that need our supports as soon as possible. And if you go back, 20 years or so, waiting until kids need a one-on-one behavior support staff is not the most efficient way to do prevention. So some of those things pushed upstream a little bit.
Thank you. I think Leslie has a question. Don't mind.
Thank you, Matt. Appreciate it. Leslie Goldman. I come from the Wyndham Northeast area, so down in the south. One of the districts that had to look outside of their DA in order to get their mental health needs met for their students. I'm wondering how you are approaching that problem. I understand it's a workforce problem. Let's just not think about that piece. What are you doing to work with the district to try and re-engage?
Well, I think it varies district by district, and that's always one of the things that makes this conversation a little complicated is what Success Beyond 6 was really built to be sensitive to the needs of the school and the district. So it looks a little bit different everywhere. What services are available, what has been developed between a DA and the school system, it all is a little bit idiosyncratic as you go across the state. So what works in one district or region may not work in another, and sort of vice versa. What we're doing to re-engage, and one of the strategies that's always worked is to really go to the schools and say, what do you need? That's how some of our best programs have been developed, is working with schools and maintaining an ongoing dialogue, and schools saying, like, look, I know you provide these services, but what we need isn't quite that. Can you do it? And, then we go back and look and say, can we leverage this funding stream in that way? Is what they're asking for a Medicaid billable service? Can we make that work? So that's certainly one of the ways we do it. Looking at cost, that is always an ongoing conversation with schools, is how do we make it cost effective for them? And that's something in these days of a lot of state budget pressure, a lot of local school budget pressure can be a complicated conversation. But being able to provide the service at a reasonable cost and then show them data, and then show them some outcomes and make them recognize that the dollars that they're spending on our services are worth it to get the outcomes that they're looking for and the supports that the kids in their district need. Those are a couple big ways. And then, you talked about sort of recruitment. That's a big one on our end. And I don't think that is just salary. I mean, that's part of it is wage and looking at wage, but it's looking at how do we make the jobs that we're looking for people for attractive to folks? How do we get them in there? Because there is a timeliness factor. And I think if you look at some of the private providers that do work in schools throughout the state is a really good example. Often they are a lot more expensive, but they will charge a much higher contract rate. But the trade-off is they can get a staff a lot faster. So from our lens, how do we balance that out and, make sure our contracts are structured and we're running efficiently enough to pay our staff a competitive rate, but we're not going completely overboard and tapping the schools for a huge contract rate to do so.
Thank you. Do you have examples of where you were able to support school to move back to the DA model rather than independent contractors?
There is a couple schools that we're working with right now. And some of the reasons why schools might have gone to an independent contractor they're back before COVID in some of these kind of situations. We're working with schools in Fairfax right now, Fairfax Elementary, which is a school that we haven't been in for quite a while. They quite some time ago, before my role in not even just this role, but my previous role overseeing school-based programs across our region. They went with a private contractor to work with a lot of their students who needed a one-on-one behavior support, kids who had autism and other kind of similar behavior profiles. And we just got back in there with them. I think part of it was just working to maintain that relationship, making sure we're maintaining open communication. And then at the time that they were ready to kind of start partnering with us again, making sure we were there to meet that need in the moment. And that's really, I think, is a key part of it, is when the need is there and when the opportunity is there, being able to put somebody in there, which goes, depends on the situation and staff availability for sure.
If
Thank
I could
you.
just mention the financial piece, because that is a critical component of workforce recruitment and all that we couldn't fill the contracts. I think the DA system at large had a challenge filling the contracts, and a school's obligated to provide the services in a lot of cases, and they're stuck. They have to go out and hire the contractor. But especially if you're awash with ESSER funds or other special COVID funds that a lot of other folks did get across the state in different industries, you do have some support to go out and hire jobs at kind of a good salary and wage that could compete with your local DA. And then when we went to more recent school budgets, I think we saw that some of these positions were the line items, the specialists, that were kind of marked for, we don't know if we can sustain these within our school budget. I think within the healthcare ecosystem overall for the DAs, the CCBHC model, for example, is going to cover a lot of the mental health side, where we're going to try to peg the system to competitive wages and get cost reimbursed. The same thing is happening, I think, with Dale and their reform. And in the same way, Success Beyond 6 would kind of fit in with that puzzle, because if we have all these other parts of our agencies functioning at, let's say, a 50th percentile of Bureau of Labor Statistics or whatever, then what does the school-based side look like? And is everybody equitable? And are we all funded in these different streams in a sustainable way? And I think Success Beyond 6 has a challenge at the moment, just because of the impacts that there's been in this sort of competition between schools and DAs. And, I can get paid more by going to the public school system. And so I'll leave the DA and go do that, or however it works. But that's kind of the financial nuance there. And it looks positive in terms of the direction that we're going as a state in some of these broader healthcare reforms and how they're paid for.
Thank you.
And I would say part of it is having some conversations like this with schools that we're having with all of you today, because I think even schools don't necessarily understand all of the value that they get by contracting with Success Beyond 6. Very often when people make a comparison for contracting for a one-on-one behavior interventionist, for example, they'll say, well, I can pay a para-educator $35,000 a year, and you're telling me it's going to cost $45,000 a year. So how is that a value for $10,000 more? And part of it is understanding that when you pay a contract rate for the behavior interventionist, that includes them being overseen by a board certified behavior analyst consultant, who's in turn overseen by a team leader that's a board certified behavior analyst or a licensed mental health clinician, depending on what the program is, who then is overseen by another person who's experienced in that, accessing kind of the full range of supports available in the DA and the connections that we make. So there's a lot more that goes into it, but schools don't always understand that part. That it's trying to do an apples to apples comparison feels easier, but it's not entirely accurate. So helping them understand what it is actually they're buying and what they get and the value of that contract is another thing that's incumbent upon us in a conversation we have to have a lot.
Thank you.
Thank you.
You can go on a little bit, Amy, a slide or two. I think that's a lot of what we have in our slide deck. I don't know if there's other questions you have about the services or the funding or how it works or what it looks like on the ground.
We talked about workforce challenges just briefly. And I'm asking a really dumb question. I'm willing to admit it's going to be a dumb question. If you're having difficulties recruiting, retaining school-based counselors. When in your hiring process, can you just pay school-based counselors more than any of your other types of counselors?
Yeah,
I'll let you go, Derek, with that.
all right, yeah, we could. Excellent question. Because we are very complex organizations that do a gamut of different services that, crisis services, our residential homes. And so we always have to keep in mind that we can't just increase rates significantly on one side of the house, because what's that going to do to our culture and the people in our organization when they say I can make $10,000 more by going over to the school-based side, and then what's going to happen to all the people that we care for in our residentials or all those different services? And so that is something we always have to be mindful of, and why we haven't been so pushing on some of these wages on that side as much as we would love to, because these are such critical services, as all of our services are. And so it is a delicate balance. And as I mentioned before, in some of these reforms, I believe that's what the reforms are trying to look at, is what does somebody living in Vermont need to be paid equitably across the state in similar roles with similar organizations and service providers, and then how can we kind of all be balanced and working together in a system that functions in a way that serves all. So, Matt, I don't know if you have anything else you want to add and what it's like actually hiring and if that's what you come up against with, but I think that's financially where we end up sometimes as a system.
Yeah. I mean, I think the short answer is yes, you can, but it solves some problems, but it creates a set of others from a broader perspective. And I would say too, as we look at the workforce challenges and what we've been facing, not all of those, I will say the legislature has been really helpful in the last 2 or 3 years in pushing some funding increases through to the designated agencies that have definitely made it better for us to hire. We still have workforce challenges, but at least at NCSS, they are not as bad as they have been. Maybe 3 or 4 years ago, we are able to meet the needs of a lot more schools a lot sooner, specifically to school programming. And I would say that's true across agency programs in general as well. But some of it is just, part of the Success Beyond 6 funding is no Medicaid dollars come without strings. And there is a lot of strings to pulling down that funding. There is a lot of paperwork. There's a lot of documentation. There is a treatment plan process that always has to be monitored and overseen. So there is a lot of that. And sometimes schools will, they'll talk to our staff and say, I can't pay you anymore. And the time off is about the same, but I can take your documentation away. You won't have to do any of that. And that's enough for people to cross that threshold. So there are other pieces just besides dollars and cents that impact the ability to recruit and retrain. Because it is, when we talk to our staff about satisfaction, that's a big one. That people will say the salary was fine and the schedule was great, but I am drowning in paperwork and I can't keep up with that end of it. So there's other pieces that we have to look. And that again is part of it incumbent on us to have conversations with the state and look internally to see if we can simplify those kind of things. But some of it kind of is what it is.
Are those conversations happening?
They are. We are always looking for it. And part of it is just Medicaid regs and to make sure that from a DMH lens, we're meeting the Medicaid regs in order to be compliant with pulling down the funding stream. But some of it is us being more creative and how do we make the process as simple for staff as we possibly can. So we do make progress on that. It comes in kind of fits and starts. We'll never get it down to where the public schools are with just being able to eliminate that piece of people's job, though, for sure.
Any other questions?
The one thing I would just like to touch on too, before anyone else, or if anyone has questions, is just something I actually talked about last year a little bit when we testified to House Healthcare. And I think something Laurel hit on a little bit is the kids who are not Medicaid. Obviously there's a lot of need in schools and kids have a lot of needs that don't have Medicaid eligibility. And that's something is looking at private insurers having to pay for some of these services that take place in schools. And I would say in home and community-based services too. This is not a conversation that's unique to school-based services where we have interventions and treatments that we know work, that are effective, that are available, but private insurance doesn't pay and Medicaid does. And therefore, part of the population doesn't have the same kind of access, even though, you know, for any of our services, schools can contract at a non-Medicaid rate. It's always available for all kids. It costs the school more, though, is the reality. So anything we can do as a state and as a system to have private insurers bear their share of the costs of providing these services for kids helps a lot. You know, that helps spread some of this out a little bit more in a way that doesn't impact the school's budgets in a huge way.
If the designated agency is providing reimbursable services to a child who has a commercial health insurance, are you able to bill the commercial payer?
It depends on what the service is. Sometimes yes and sometimes no.
If it is a service that they reimburse for?
For the commercial payer,
Yes.
if it is something that they reimburse for, yes, as long as in school-based services, you know, a lot of times the staff has to have a certain credential to roll through all of that. So in that case, yes. But for example, like behavior intervention services are not something that private insurers pay for. So it depends on what it is. Sometimes the answer is yes to that. And then that's true for home and community-based services as well.
And for the services that you are able to be reimbursed for, are the rates that the commercial payers pay equivalent to Medicaid, less than Medicaid, more than Medicaid? Typically.
I'm looking at Derek for some specifics. It varies a lot. Private insurers, their rates are kind of all over the place. You know, I think the time that I've been deepest involved with that is I oversaw our program that provided services based in applied behavior analysis to kids with autism that was funded through DEVA as well as private insurers. And those private insurers rates were all over the place. They were structured differently. Some had a lot of hoops that you had to jump through to be able to hope to access them. So it varied pretty wildly. But in terms of the services we're talking about, I'm not sure, Derek, if you know what the private insurers rates are for some of that.
We could pull eligible services. We could get that. I mean, we're looking at all of our services with the CCBHC and, you know, what's billable and in and out. Can take the eligible services that may apply to school-based, put in the Medicaid rate, and then what some commercial rates might. I don't know. Actually, I don't think we can do that because commercial contracts, I don't think allow you to share broadly, but we could at least say lower or higher, maybe. I can try to pull that data for you.
Thank you. And thank you, Derek and Matt, for joining us today. Can I just ask the committee real quickly, can I indulge everyone 10 minutes into their lunch? Are you have a meeting?
Yeah.
Discrimination. Okay. Well, I'd like to hear from Abby really quickly, and I know our legislative council has joined us. So if we could just quickly, and we'll try to get through as quickly as possible.
Thank you for your time.
Thank you. Hi, Abby. Welcome.
Hi there. Thank you. Oh, there we go. I thought I froze for a moment. But good morning to you all. The Vermont School Counselor Association that I'm a member of. Oh, and hi, Ian. Ian is here as well, representing the Vermont School Counselor Association. But we really appreciate the opportunity to come and speak today about the mental health needs of our Vermont students. VITSCA's mission is to represent the school counseling profession and equip school counselors to create equitable opportunities and inclusive environments that enable all students to succeed. So my name's Abby Allen. I am a member of the Vermont School Counselor Association Advocacy Committee and a school counselor at the Central Vermont Career Center in Barre, Vermont. And I am here providing testimony on behalf of the Vermont School Counselor Association. Unfortunately, there is still an increase in social, emotional, and mental health needs amongst our student populations. Examples of these include an increase in anxiety, stress, and depression, self-harming and suicidal ideation, an increase in food, financial, and housing insecurities, decreased motivation or capacity to attend school or remain present in school, increased aggressive behavior, especially at the younger grade levels, a lack of coping skills, and difficulties managing personal and social boundaries. These often lead to challenging behaviors. In turn, without more tools to manage these behaviors, students are sometimes caught in a debilitating cycle that impacts their ability to attend school, impacts their academic success, impacts their sense of belonging, and impacts their ability to thrive in the school environment. Behavior is a means of communication, whether it's in the heart of Chittenden County, the most northern or the most southern part of our state. Our students and families are communicating the same thing. They're telling us that they need more support, and this is why we are with you today. Thankfully, school counselors are uniquely positioned within the school community to support the various needs that arise, mostly at a Tier 1 level, meaning that school counselors provide supports to all students in the areas of mental health, academic, and career and college planning. However, given this increased and amplified nature of these needs, current models and ratios of school counselors to students are no longer able to meet this increase of needs, thus affecting delivery of a comprehensive program. In addition to these concerns for all schools, there's an elevated concern for more rural schools that are already located in areas where transportation and access to necessary mental health services are few and far between due to the scarcity in transportation and barriers with funding structures when it comes to school-based clinicians and social workers. The bottom line is that the need for resources is high and the access to funding and resources is low for many schools. In addition, access to community mental health supports throughout the entire state have long wait lists, and families are having difficulty accessing mental health care in their communities. As a result, school counselors are often met with an ethical dilemma of sticking strictly to the role of the school counselor or wearing multiple hats to attend to the immediate concerns, needs, and challenges in front of them every day. School counselors who are in the profession dedicated to mental health services should not have to sacrifice their own well-being to carry out the job that we love so dearly. As with many things in our community, one of the largest challenges is money. With so many other variables in the mix, it makes it even more difficult to advocate for the necessary resources to better help our student bodies across the state. Students benefit from comprehensive school counseling programs, with school counselors focusing on the areas in which they are experts in. Some schools, unfortunately, have reduced school counselor support, causing increased student-to-counselor ratios. More school counselors means more preventative programming and early intervention. It means more direct service. It is a proactive and not reactive, providing intentional supports for students, staff, and families. It means more time dedicated toward mental health, academics, post-secondary planning, and other things that are often pushed to the back seat in order to attend to the reactiveness of immediate needs. Increased school counselors means more capacity for implementing school-wide and systemic initiatives with lasting success. More school counselors means an investment in our future citizens and leaders who deserve a healthier childhood. To highlight a recurring theme that the current needs of our communities are outweighing the capacity of school counselors. More school counselors would remove debilitating barriers and allow us to more effectively carry out services to our youth and families with less burnout. Thank you again for your time this morning, almost this afternoon. We're grateful for the opportunity to share with you what has been shared with us each and every day by those in our communities. Thank you all.
Thank you, Abby. And I know our time is short.
Yes.
And I appreciate you joining us. Could you send us your written testimony?
Yes. Yeah. I believe we're gonna make sure the Vermont School Counselor heading is on the testimony, and we will make sure to get that to you all.
That's fantastic. Any questions for Abby or Ian, who's joined us? Thank you. Thank you so much.
Thank you so
for
much,
the
everyone.
important work that you do for our kids.
Yes. Thank you.
Thank you. All right. We're gonna pivot really quickly to Jen, Ledge Council. I've asked her to walk us through H96, which is the bill we have on our wall regarding certificate of need. I think we've heard an awful lot about certificate of need at this point. So I just wanted her to walk through that. And we're going to take testimony on that this afternoon.
Great. Good late morning. This is Jen Kirby from the Office of Legislative Counsel, and we are looking at H96. was sponsored by some members of this committee. This is an act relating to increasing the monetary thresholds for certificates of need. And as you may recall from what you've heard so far, the jurisdictional trigger for needing to get a certificate of need is often a dollar threshold. And so this bill would increase the amounts that trigger that jurisdictional threshold. So for a healthcare facility other than a hospital, it would increase the trigger for a certificate of need for a new healthcare project, which is defined. So construction, development, purchase, renovation, or other establishment of a healthcare facility, or any capital expenditure by or on behalf of a healthcare facility. Currently, the threshold is 1.5 million in capital costs. This would increase that to 10 million in capital costs. And I should say there's numbers here in the statute. The ones that are being crossed out are the statutory numbers. There is authority in the statute and that is exercised by the Green Mountain Care Board to increase those thresholds, to index them so they are slightly higher than the numbers that are in here under current law, but not anything close to what they would be increased to. So this would reset the statutory thresholds with that same indexing authority.
By changing it to 10 million, would it also still continue to be indexed?
Yes, so that indexing provision, that indexing language you'll see at the end would actually change it from a discretionary indexing increase to a mandatory. So, all right, so this number that would increase goes from 1.5 million to 10 million for a non-hospital. The purchase, lease, or other comparable arrangement of a single piece of diagnostic and therapeutic equipment, again, that's for under the non-hospital, for which the cost or donation is in excess of, and this would increase from the current statutory 1 million to 10 million. The offering of a healthcare service or technology having an annual operating expense that exceeds, and under current law, it's 500,000. This would increase that to 10 million for either of the next 2 budgeted fiscal years if this service or technology was not offered or employed by the facility within the previous 3 years.
Leslie?
I'm not sure if you want questions now or at the end.
If it's the question I'm thinking of asking, you can go ahead and ask it.
Let's see if I'm reading your mind. I didn't understand this operating expense kind of language and how this fits into CONs.
I was hoping you could explain basically what operating expenses are.
So I will defer to the board to tell you how they interpret it. My understanding of it is about the expenses related with actually using or running the service or technology as opposed to a capital expense. So I think it's the sort of the other side of the capital expense is the builder purchasing, and the operating expense is actually using it.
And is that well, you might not know this, so I should ask later. Is that, because are there examples of operating? I just want to understand.
I think the board folks
Board can answer that.
and others who.
Yeah, Chair Foster will be in at 1 o'clock, so save that question for him.
All right.
Oh, yes, I'm sorry, Woody.
I'm curious. Why do we have these separate areas? Why can't we just combine them all in one and just say,
So what do you mean separate areas?
well, we have construction development, we have equipment,
Operating expense.
Well,
yeah.
previously, as you can see, the numbers have not been the same. If you are looking at making them the same, we could certainly examine whether it makes sense to consolidate.
I'm just curious. It just seems like.
Yeah, I think there have been, just with the different costs of things, they had distinguished what would trigger a CON requirement. And for some things, that was a lower threshold. And for other things, it was, they would be reviewing too many proposed projects if the threshold were lower.
So they had to separate them out because they wanted different values.
I assume so. And the statutes have been added to and amended over time as well.
So it is easier, I guess, than in the past.
Yeah, so I mean, in this proposed bill, the numbers are, many of them anyway, are $10 million. So if there was interest in, consolidating all of those
It's just a thought.
We could, it may also make sense to index at different rates depending on the category, but the board have a better sense for that. On page 3, number 6 is the construction, development, purchase, lease, or other establishment, and this would add or expansion of an ambulatory surgical center. There's currently no monetary threshold. Any ambulatory surgical center would need a certificate of need. This puts in a threshold of a cost exceeding $10 million. So it adds both the expansion of an ambulatory surgical center and also a monetary threshold. So that was non-hospitals. Then we get the hospitals. And again, in this proposal, it would, I'm just going to shorten to construction. It would have increase the construction threshold from $3 million to $10 million. Also increase for the single piece of diagnostic and therapeutic equipment, go from $1.5 million to $10 million. The offering of a healthcare service or technology with an annual operating expense, again, increase from $1 million to $10 million. Yep, and there, I have to say, there's also, in the Senate, there were 2 bills that had different proposed threshold, increases that were not all the same. So the first time I ran through this, I was sort of comparing the 2 of them. Right now, there's a lot of 10 millions. And then in subsection C, in the case of a project that requires a certificate of need, if it's going to be, if the expenses are anticipated to be very large, so if in this case, under existing law, if they're expected to be in excess of $30 million, this would increase that to $50 million. The applicant first has to get a conceptual development phase certificate of need. So they get a kind of early stage certificate of need and then get a regular certificate of need. And so this would increase that threshold from 30 million to 50 million. The change on page 4 is just, page 5 is just a conforming change that reflecting that same 30 million to 50 million. And then this increases the amount that the facility can spend in preparation for obtaining a conceptual development phase certificate of need. Right now, that is $1.5 million for non-hospitals or $3 million for hospitals, and this would increase that threshold for both types of facilities to 10 million. And then they would have a new exclusion in it. So under existing law, there are a number of types of facilities and other projects that are exempt from a certificate of need requirement. This would add a new exclusion for the offering of a healthcare service or the construction, development, purchase, renovation, or other establishment of a healthcare facility that is the result of a contract awarded by the state. So let's say if something is happening, if some kind of healthcare project is happening because there was a contract awarded by the state, then that doesn't need to go through certificate of need. There's already been presumably, I suppose, and I'll let the proponents of this explain, but I think that the rationale would be if the state has awarded a contract, the state has determined there is a need.
Well, that's an interesting, that was a question for me, this provision, and you may not want to be answering it, is like, well, what if they want to build something on a wetland? You know, how does that work?
Yeah, I would defer to the proponent.
Yeah, and who is that? I mean, is that the Green Mountain Care Board? Oh,
Well, right now, the
that's you.
proponent, the
Got
lead
it.
sponsor is sitting next to you,
Sponsor,
yes.
I mean, I would need backup information too, but I don't think any of this would prevent an entity from having to go through all the
Zoning and, yeah.
Yeah.
Well, the state. I don't care about other,
So this is an exemption from the certificate of need requirement, which is effectively, whether there is a need in this state for the facility or service that is being proposed.
You would still have to follow state law around wetlands protections and.
Yeah, I sort of would want
And the
that.
board doesn't get into that.
Yeah,
It's
so
not their
it's,
jurisdiction.
yeah, it's sort of confusing to me. It sounds like a blank slate and it may not be.
It's just excluding from the subchapter on certificate of need, which we can look at in context may help.
Yeah, that would be
see.
helpful to know, I want to understand the protections, and not that I'm not trusting the state, but
I think it only applies in the subchapter.
Yes, it only applies to the subchapter on certificates of need, on
Yeah.
health facility planning under certificate of need.
so there's something in there that the ellipses or up there.
Well, that's just a list of other things that are excluded. So individual providers' offices are not subject to a certificate of need requirement. There's other types of facilities that are not subject to a certificate of need requirement. It doesn't exempt them from any other part of the building planning zoning requirements of the state. It's just saying a certificate of need is not required. Doesn't require the board to go through the jurisdictional analysis, and there's a whole process set out in statute for what it looks like to seek and grant a certificate of need.
I may need help understanding that and another.
Yeah, and we can look through the certificate of need statute.
I think I just wanted to do a quick walkthrough, just so everybody see it, before we start taking testimony on it.
Okay.
Any other
Can
questions,
be-
Jen, regarding what's in here?
The two questions. Okay.
And I may be able to join you for some of this afternoon, depending on how long I am down the hall.
Yes.
And we appreciate you coming